Good evening, everyone. I'm Tony Segreto, and once again, so very honored to be your moderator for this In the Know Town Hall. Tonight's Town Hall is an opportunity for us to share the work of Sylvester Comprehensive Cancer Center, its research advancements, clinical care, and response to COVID-19. As you all know, the COVID-19 pandemic has disrupted every single aspect of our lives, but nowhere is that more evident than in the way patients seek treatment and interact with the healthcare system. COVID-19 has changed the very nature of our response to urgent care and our ability to access safe and timely medical interventions. In health centers around the world, in fact, it's also influenced and in many cases interrupted critical non-COVID-19 related research. So the question is, how is all of this affecting the field of oncology? And more importantly, how is Sylvester making strides in innovative research and comprehensive care while keeping patients, healthcare workers, and staff safe? Well, we are extremely fortunate tonight to have some of the greatest minds at Sylvester to help us explore those questions. Please join me in welcoming Dr. Stephen D. Neimer. He's the director of Sylvester Comprehensive Cancer Center, the Oscar de la Renta Endowed Chair in Cancer Research and Professor of Medicine, Biochemistry, and Molecular Biology at the Miller School of Medicine. He will lead the question and answer session tonight, along with Dr. Macarena de la Fuente, who is the chief of the Neuro-Oncology Division in the Department of Neurology. She is also the Neuro-Oncology Clinical Service Leader of the Oncology Service Line at Sylvester Comprehensive Cancer Center. And we will also hear from Dr. Ricardo Comatar, Director of the Sylvester Brain Tumor Initiative at Sylvester Comprehensive Cancer Center. Dr. Comatar is also the Director of Surgical Neuro-Oncology and the Neuro-Oncology Fellowship Program in the Department of Neurological Surgery at the Miller School of Medicine. Now, before we get started, let's go over how you can participate in tonight's conversation. Once we are done with opening remarks from Dr. Neimer, all panelists will answer questions that you've submitted over the past few days. But you will also have the opportunity to submit questions during this program. All you need to do is down at the bottom of your screen, you'll see that Q&A feature there. Send us your questions. They'll be submitted anonymously, and we will get to as many of them as we possibly can tonight. But now, it is my honor and my distinct pleasure to introduce Dr. Neimer, Director of Sylvester Comprehensive Cancer Center. And Dr. Neimer, as always, it's so great to see you, sir.
Thank you so much, Tony. We're delighted always to be with you and to have an opportunity to talk to the community at large and discuss some very important issues. Tonight, COVID-19 and cancer. As you said, we've had to reconsider every aspect of the care that we deliver, not only to cancer patients, but to all our patients at UHealth. I want to give a shout out to the teams of people in the hospital, in the clinics, throughout the entire university who've helped us working to get the absolute best practices to keep our patients safe, to keep the physicians, all of our employees, nurses, staff safe in this really unprecedented time. You know, the decisions that we make are always best if they're driven by data. And compared to March, when the first cases were appearing in Florida, to now, we have so much new knowledge. We have some treatments that we're using to keep people safe. And we also have new practices in terms of how we handle patients through our system. I want to start for a moment and just talk about our COVID testing. We have established the ability to test internally 500 or 600 people a day. And this has been a game changer for us. You read about it taking 5 days or 7 days to go through the commercial labs to get test results. And we're now at the point, for instance, if patients come to our emergency department seeking care and they need to be admitted, we want to get the test results within 4 hours for the patients that get admitted. And over 90% of the time, we're able to do that internally by setting up our own testing capability through our Department of Pathology. And in addition to that, we have set up testing lines, a phone number that anyone can call if they're concerned that they may have been exposed or that they have symptoms so they can get tested. We've set up testing facilities, not only in Miami here downtown, but in Lennar and in Deerfield Beach in Broward County. And we've also worked to set up these testing guidelines. Which patients need a 4-hour turnaround, which patients would be tested before within 24 to 48 hours. And so now, for instance, any patient who's about to begin chemotherapy gets tested. Any patient before they begin radiation therapy gets tested. We treat all patients as though they may have COVID, so we don't want to infect our healthcare workers. But we also know that for certain procedures and things, people who are positive may be at higher risk. And so for things that can be delayed, we prefer to delay until the viral infection has gone away. If you come here, there's no valet parking. And we've had to institute one of the most difficult policies, which is the no visitor policy. And also, we've increased our cleaning around the facility. We've eliminated chairs. We have a system in place where people don't even wait in the waiting room anymore. You can be in your car. As soon as the doctor is available to see you, you get a text message and you can then walk into the building, go see the doctor without having to sit in a waiting room. We've moved a lot of things to telemedicine. At one point, about 80% of all the visits were done by telemedicine. And more recently, we've been able to accommodate more people in person. And so we're now doing a combination of telemedicine and in-person visits. We used to do 100 telemedicine visits in a month, and we're now doing over 1,000 a day. And so it's really changed the way we can deliver care. We also have some new devices that we've purchased that allow us to do a program called Televigilance. So people who have COVID or who are at risk, we can monitor on a daily basis through telemedicine at home. The other things besides the COVID things is how do we maintain our research activities, the clinical research, the experimental therapeutics, the drugs for patients. As you know, about a year ago, we became an NCI designated cancer center, one of only 2 in the state and the only one in South Florida, and one of only 71 in the United States. And tangibly, what that means for people in this region is that there are treatments available only at NCI designated cancer centers, and that those treatments are available at Sylvester. And so people don't have to leave the region to get these treatments, to get cutting edge therapies. And you'll hear tonight from doctors Comatar and Dela Fuente that all the exciting things that are going on that relate to the ability to use cutting edge technologies to treat and to hopefully cure patients of cancer. In the 5 months or so that we've been under the COVID pandemic, we've actually put over 100 patients on clinical trials. Typically in a year, we may put 500 people on trials. And so while we've had to deal with the reality that people for a while were afraid to come to see the doctor, that we've mounted some confidence building campaigns, instituted all the things I've mentioned. And so we are continuing to open new trials, immunotherapy, targeted therapy trials, and that we've also been able to recruit some new faculty members who are also going to be involved in expanding the clinical trials that we have to offer our patients. Our stem cell transplant program has been very busy throughout this pandemic. We continue to give radiation therapy to many patients. We're at about 95% of the level that we were doing before COVID, which is really remarkable because every patient that we take care of now requires the nurses to put on what we call PPE, to take it off. The act of taking care of even a single patient now is very much more difficult than before, and our staff has really stepped up to the plate and done an amazing job. There are some unfortunate facts that we have to deal with about the pandemic, that we had no elective procedures for a number of months, And we know that things like mammograms and colonoscopies can save people's lives, can diagnose cancer early. And so it's been estimated nationwide that there may be 50 to 60,000 cancers that have gone undiagnosed over the last 5 months or so. And also then subsequently is that patients may have more advanced cancer when they come in. And so it's absolutely critical that we have the ability to do all the imaging procedures and stage the patients properly and have treatments available for each and every patient depending upon the disease and the stage of the disease. Our precision medicine efforts have continued unabated. And tonight we have an opportunity also to focus in a bit on the brain tumor programs. We have two really superb, I've been a doctor now for 40 years, and so I can call everybody young. So we have several young colleagues here that are incredibly experienced. All three of us share the experience of either being being a professor or receiving training at Memorial Sloan Kettering Cancer Center in New York. And I think it's a testament to what we've been doing at Sylvester and at the University of Miami that we've been able to recruit outstanding physicians and diagnosticians and researchers like Rick Comatar and Macarena de la Fuente. And before I end my very robust opening remarks, let me say that the Cancer Center has benefited greatly from investments by the institution, by the university. The state of Florida has been very generous in supporting our pursuit of NCI designation, and the community has been great, giving us philanthropic support and helping us get the message out about the programs that we are building, which are not the best in Miami, they're not the best in Florida, but they're among the best in the world. And so when I say they're not the best in Miami, they are the best in Miami, but they're not only the best in Miami. And so this is what we've been able to do with the investments. A lot of private foundations are hurting right now. They've had difficulty raising money. Some of our researchers have received grants that actually they've had to withdraw the funding of some of the proposals. And so during this time, our labs have been worked for several months not doing research in terms of the laboratory research. Now we're working at about 40 to 50% of capacity. And we hope that as the pandemic is seemingly getting under a bit of control down here, that we'll be able to fully resume all the cancer research in the laboratory that we need to do to make the discoveries that'll be in the clinics 5 to 10 years from now. So thank you so much, Tony, for giving me the opportunity to expound a bit, and I'll turn it back over to you.
Thank you, Dr. Neimer. That was wonderful. For setting the stage, certainly, as we move into the Q&A portion of this event now, let's turn our attention to questions submitted by some of you over the last few days. And our first question is for you, Dr. Comatar. I've heard that Sylvester has the highest volume brain tumor program in Florida. You're leading one of the busiest centers. What does that mean for patients, especially during a pandemic?
Sure, and thanks for having me on this show. It's really a pleasure to be here. Looking at the data throughout the state, it's very clear that the University of Miami and Sylvester treat by far the most brain tumors in the state. What that translates into is better overall outcomes for these patients. That's been studied before on a very large scale, looking at national databases even. And the centers that are high volume brain tumor centers, ones that treat not just 50 or 100 or 200 brain tumors, but centers that really treat close to 1,000. I mean, we treat about 1,200 a year. Those types of centers have better outcomes. So it's not someone's opinion. It's not just subjective. It's actually objective data that these complicated conditions do better at a subspecialized comprehensive cancer center like Sylvester that does the highest volume in Florida. So in short, what does that mean for patients is that patients who have brain tumors are going to do better looking at the data at Sylvester than they would at a smaller community medical center.
Doctor, thank you. Dr. De La Fuente, Sylvester has recently received NCI designation, as we heard earlier, for its outstanding work providing South Florida cancer patients with innovative cancer care. As one of the physicians steering the fight against cancer, can you enlighten us on what the brain tumor program at Sylvester is doing that's different to make improvements in both treatment and outcome of patients with glioblastoma?
Yes. Good evening, everyone. Thanks so much, Tony, for your introduction. I'm very honored to be part of this panel today, along with Dr. Neimer and Dr. Comatar. I would like to say that yesterday was the second glioblastoma awareness day. So having the opportunity today to discuss brain tumors, bring awareness and hope to our community is very exciting, especially during this very difficult time. But going back to the question, we at Sylvester are constantly searching for innovative treatment modalities that extends the life of our patients. Our program is on the cutting edge of surgeries, imaging, molecular sequencing, clinical trials, with the ultimate goal to find better therapeutic approaches for our patients. Depending on the tumor type, the approach may include sophisticated surgery or radiation therapy, a standard of care chemotherapy, or a clinical trial. A clinical trial is a research program conducted with patients to evaluate a new medical treatment. At Sylvester, we have multiple clinical trials available for brain cancer patients. We have trials using targeted therapy. That means a treatment that especially targets a particular alteration that the tumor has. We have clinical trials using immunotherapy with the intent to release the brakes of the patient's immune system so it can identify and attack the tumor. Trials with vaccine therapies and more. The range of treatment options that we can offer now to our patient is completely different from 5 or 10 years ago. But to really understand the impact of our research, I would like to tell you a short story about one of our patients treated in one of these trials. So about 4 years ago, I evaluated a young patient for a second opinion. At that time, she was in her early 20s, was diagnosed with a recurrent glioblastoma, and she was told that her life expectancy was about 6 months. So we analyzed the molecular makeup of her tumor and identified a rare mutation. She was enrolled in a clinical trial using oral drugs that target that particular mutation. So now, 3.5 years later, she is doing great, is working full time, studying, living her life. And that is our goal. That is what we strive to achieve for every single patient that we have the opportunity to care for.
Such a great story. Dr. De La Fuente, thank you. Dr. Neimer, how is Sylvester managing a high clinical volume of cancer surgeries, radiotherapy, and chemotherapy as we see an increase in COVID-19 hospitalizations?
Thank you, Tony. What we've instituted really is, in essence, two hospitals. So the University of Miami Hospital, UHealth Tower, has areas for COVID patients, and then most of the hospital is available for patients that are not COVID positive. And as I mentioned, before we admit any patient to the hospital, we check and know within 4 hours whether or not the patient has COVID virus. And so Sylvester Hospital, which is a separate building, really has no COVID positive patients. And so and that is mostly the outpatient part of our activity here in downtown Miami, although we do have our stem cell transplant patients there. And then we have the satellite facilities, where in all cases, patients have to come in wearing masks. We have appropriate personal protective equipment. We practice social distancing. And we've been able to spread out chemotherapy. So instead of having a patient in every chair or every bed, we have every other bed or every other chair. And so we have been extending our hours and working late to make sure that we can accommodate all the patients. It's known to everybody on the call that if you have cancer, the cancer doesn't care if you have COVID or not. The treatments for many cancers are immunosuppressive, and so cancer patients are less able to fight the virus. And so we're super vigilant to make sure that our facilities are clean, that we don't, for instance, test people for COVID virus in the same areas where we have patients. We've set up these testing facilities that I mentioned that are drive-through facilities, and so that we never commingle a patient who may have a fever or respiratory symptoms with any of our cancer patients. And then, as I mentioned earlier, before we do anything for our patients, cancer patients, beginning surgery, beginning radiation, beginning chemotherapy, we test everybody for the presence of the virus. And that's allowed us to continue to take care of people and to make sure that our staff are safe and our patients are safe.
Dr. Neimer, thank you. Dr. Comatar, how do you prioritize the management and treatment of primary brain tumor patients?
That's an excellent question. We see several hundred primary brain tumor patients per year here at Sylvester. The issue is that normally there's no problem fitting them in for surgery or biopsy because we have the room and we have the space. With COVID, there's obviously a very tight situation here at the hospital. And in particular, it really depends on the ICU bed. So everyone who has a primary tumor removed needs to spend one night up in the neuro ICU, and then they go home the next day from the neuro ICU. But it's dependent upon having that bed available. What COVID has done to the hospital is obviously it's pulled a lot of those resources, a lot of those nurses, a lot of those beds are taken up by COVID patients. So you definitely run into a situation where, let's say you have 4 people who all need surgery for their primary tumor, but there's only 2 beds available, or there's 1 bed available, or there's no beds available. And so what you have to do is start to stratify the patients. Low-grade tumors, which are less of an emergency, high-grade tumors, which are more of an emergency, younger patients, symptomatic, size of the tumor, all of that plays a role. What's most important is that our team is willing to work pretty much any time of the day to get these patients treatment. So, for example, we had patients last week who needed surgery, 2 high-grade tumors, obviously needed surgery within a certain period of time, and there were no beds Thursday and Friday. Beds opened up on the weekend. We came in, we operated on Saturday, we operated on Sunday. And so it's just an example of how we put patient care first. And in these situations, you have to be flexible. You have to be able to stratify these patients. And then as beds become available, you can take care of them. So every patient is different. We look at, again, the age, type of tumor, symptoms, and the bed availability. And we slowly take care of these patients, but within a certain time frame.
Dr. Comatar, thank you. Dr. De La Fuente, here's a question that was sent in a couple of days ago. Given all the developments that you have mentioned and the direction that research at Sylvester is taking for brain tumor patients, what new innovative ideas are you currently most enthusiastic about, and what are your hopes for the future of neuro-oncology?
So at Sylvester, we deliver cutting-edge cancer treatments by connecting our scientists with our clinicians, taking our research from the lab into the clinic so it can directly benefit our patients. For example, we just finished a clinical trial, an immunotherapy clinical trial, with a vaccine that we generate in-house, specifically designed for the tumor of that particular patient. So what we did is Dr. Comatar and his team removed the brain tumor, and we brought that tissue to the lab, and we draw blood from the same patient that had the surgery, and we took some white blood cells from that blood. And in the lab, using small pieces of the tumor, we trained those white blood cells to identify the patient's tumor. So then we inject the white blood cells back into the patient as a vaccine, so the patient's immune system can identify and attack the patient's tumor. So the trial was all done in-house at Sylvester and demonstrated to be safe for the patient. So all of this was possible because of the research infrastructure that Sylvester provides to us as researchers. Another example of promising treatment are IDH inhibitors. As we discussed earlier, we researched the molecular makeup of our brain, of the brain tumors. And IDH mutation is a highly prevalent alteration in these tumors. So we are leading the way in clinical research with IDH inhibitors, so drugs that target these mutations. We are the only cancer center in Florida that has participated in every single clinical trial with these drugs. We led an international study that includes more than 35 cancer centers, which data we just present at ASCO, which is the most important oncology meeting in the world. Now we are again the only cancer center in Florida offering the first phase 3 trial using IDH inhibitors. So we hope that this will make a huge impact in the life of patients with IDH mutant gliomas.
Dr. De La Fuente, thank you. Dr. Neimer, this was just sent to us. It seems like a lot of research, this is kind of a two-part question here. It seems like a lot of research funds are being directed toward the current pandemic. How do you see this impacting the pace of cancer research? And the second part of that question is, what areas of cancer research are most in need of donor support?
Thank you. So the first part of the question is relates to funding, and we are trying to get some funding for our COVID research. It turns out that when people are infected with this virus, it triggers an inflammatory response. Actually, there's a drug that we give to patients getting immunotherapy, which is a very important drug to give to people with COVID. And so there's some overlap in terms of the research, and we're hoping to gain knowledge from our research on COVID that'll help cancer. The National Cancer Institute is the major funding source for grants in the United States. And the good news is that the federal funding for cancer research is actually going up despite all that's going on. And so we're hoping to continue the research. But what's happened also is that the ability to conduct research has been hampered. That we've found that we can have, now we have one person working in every 200 square feet of lab space. And so a lab that's 1,000 square feet used to have 10 people working, and now maybe it'll have 5 people working. People are working in shifts, and it's been much more difficult to get the research done. Our focus has been on some very important areas: epigenetic therapies, targeted therapies, new vaccines. We've been leading the efforts in using viruses to kill cancer, brain tumors and otherwise. And so I would say that there are a number of very specific areas of research where we are trying to lead the efforts, and we need funds not only to get the research done, but to get it done quickly so that we can help people now and not 2 or 3 years from now.
Dr. Neimer, thank you. Dr. Comatar, you sort of touched on this earlier. As a brain tumor surgeon performing hundreds of procedures a year, how has the new technology contributed to your success?
I would say that the technology is a huge piece of our success. I think any comprehensive brain tumor center needs to offer the latest technology because neurosurgery in particular over the last several decades has really advanced and continues to advance essentially yearly. And the new technology allows us to take out tumors easier, safer, quicker. And I'll just go over a couple of those technologies. One is the laser ablation. That's a relatively new technology. It's probably about 5 or 6 years old. Small catheter, about 3 millimeters, that you put deep into the brain. And then you can control the temperature at the tip of the catheter very precisely and essentially burn the tumor from the inside out. So when you're dealing with patients who have tumors that are deep in their brain, normally prior to this technology, you would have no real surgical options. A lot of those patients didn't have any hope. Laser ablation is a minimally invasive, effective way to treat these otherwise inoperable tumors. We also do a lot of awake craniotomies. These are tumors that are near areas of the brain which control language or movement. In those situations, you want to be able to do the surgery with the patient awake. What that means is that for a small part of the surgery, probably about half an hour, 40 minutes while you're doing the critical part, the patient is moving or they're talking or they're listening. And that way you can monitor their function and be more aggressive in those areas. So we do the most awake surgeries in the country. We do somewhere between 100 and 150 a year, just awake craniotomies. So that's a big advance, especially when you're dealing with these very complex tumors. You have to be able to do these surgeries awake. We also have a robot, which we've had over the last year. When you're doing biopsies, when you're doing laser ablations deep in the brain, the robot essentially takes out all of that human error. You basically pick your starting point, pick your end point, and the robot lines it up such that it really minimizes human error, which can happen during any surgery. So having a robot to do these precise procedures really decreases complication rates. We also have a tubular system, which is it's a small, clear, about maybe 2 to 1.5 centimeter tube that you can place into these tumors and remove them again with these deep-seated tumors that otherwise you would have to damage a lot of brain. We also have dyes that can be given to patients intravenously. This dye is taken up by the tumor and not by the rest of the brain. So when you operate on the tumor, the actual tumor lights up like a light bulb and the rest of the brain doesn't. So you can see exactly where the tumor is. There's no debate about, is the tumor all out? Is that normal brain? Is that tumor? Really helps the surgeon to get a more effective resection. We also do a lot of surgeries through the nose. So a lot of tumors that are in the skull base, just here right above the eyes, those would typically require a much larger morbid surgery. But now that we have the technology, we can go up through the nose, which obviously has no scarring, less pain. Patients go home quicker, and you can take out these large aggressive tumors and still maintain quality of life. So, thanks to our team, thanks to the Cancer Center for really supporting us, because obviously this is not cheap, but getting all the equipment together has been very easy to do here. Everyone is very supportive, and it's really led to a very comprehensive brain tumor program.
Dr. Comatar, that's unbelievable to hear all those things that you can do now with this technology. Dr. Dela Fuente, it seems that medical information about COVID-19 and oncology is changing every single day. How does COVID-19 affect the central nervous system, and what kind of additional complications does it cause in cancer patients?
So we have seen a variety of neurologic symptoms in COVID-positive patients, from headache and anosmia, that is an alteration of the olfactory sense, to less frequent but severe symptoms as altered mental status and severe muscle weakness. Of course, patients on chemotherapy and on other cancer-related treatment are basically at increased risk of infection in general. So the priority is to avoid exposure to the virus to prevent infection. So we keep reinforcing to our patients to stay home, to practicing social distancing, wearing masks, reinforce proper hygiene, and also lets us know if they had been exposed to a COVID-positive patient or if they have experienced symptoms concerning for COVID infection before coming to a scheduled appointment, so we can have a plan in place ahead of time.
Doctor, thank you. Dr. Neimer, how does chemotherapy increase the risk of severe complications from COVID-19?
Tony, in part, many of the chemotherapies that we give affect the immune system, host defense, they lower the white blood count. And so the chemotherapy can make it more prone for people to get infection. There's also the risk once you develop an infection that your body will be less able to fight it off. And so we are hesitant, and in fact, that's why we check everybody for COVID before we start chemotherapy, is that we would delay chemotherapy in anybody who is COVID positive. There are also some areas of chemotherapy where immune system may be required in order for the treatments to work. And so people who have COVID, while they're infected with the virus, their immune system is directed at the virus, and they may not be able to respond as well to the treatments themselves. So it's both keeping the patient safe and also delaying sometimes the treatments to make sure they can be effective.
Dr. Neimer, thank you. And Dr. Comatar, are there additional precautions patients with brain tumors should take after treatment to protect themselves from COVID-19?
I think anyone that undergoes anesthesia, surgery, is on Decadron, which is a steroid commonly after brain surgery, you're going to be more vulnerable after any stressful procedure and those medications. So your immune system is going to be lower than the normal person. I think just common sense. I think hand washing, social distancing, wearing a face mask, staying at home unless you absolutely have to go out. There's nothing really in particular that they have to do other than just being more adherent to the CDC guidelines than you normally would be, because your immune system is going to inherently be lower, especially immediately following surgery.
Dr. Comatar, thank you. Dr. De La Fuente, we just heard about physical distancing. We talk about it. I know that President Frank likes to call it something, it's physical distancing and not, social distancing. How are you seeing families cope with the physical distancing standards that require patients to undergo treatment without loved ones accompanying them?
So caregivers of patients, especially with patients with newly diagnosed brain tumors, are at high risk for distress, anxiety, depression, due to the overwhelming nature of the diagnosis and also the need to assume the role being caregiver essentially overnight. This has been even more difficult during the pandemic because at almost every hospital in the country, caregivers are no longer allowed to accompany the patients. So we are taking advantage of technology. We are using different approaches like telemedicine, or if the patient needs an in-person visit, we do a video call with the family member so they can participate, ask questions, and be involved in the care. And we discuss with the patient and the caregivers which approach may accommodate better the needs of that particular family, and we work together with that.
Dr. De La Fuente, thank you. Dr. Neimer, back to you. Which Sylvester clinical trials are you excited about, and which ones have promising outcomes for patients and for oncology in general?
Well, I think I'm going to expound a little bit on what Dr. De La Fuente was talking about, which is the IDH mutations. What we're learning is that cancer is not a monolithic disease. So we used to think of lung cancer in one of two types. We now think of lung cancer as one of 20 types. When we think of brain tumors or leukemias, we now can understand them on a very different level, a molecular level. And what we're finding is that some of the drugs that are used for one type of cancer can be useful for others. Dr. De La Fuente talked about IDH inhibitors. She didn't mention that she's one of the world's experts in using those, but they've currently FDA approved to treat leukemia. and Sylvester physicians have been among the first to treat patients with leukemia in the world with those inhibitors. The immunotherapy approaches, there's something called CAR T cells, chimeric antigen receptor T cells, where you take immune cells out of the patient's body, you supercharge them so they can all then be redirected against the cancer, and then you reinfuse them. For children with leukemia, they can be curative in over 90% of the children, even though they may have failed a bone marrow transplant. In adults with lymphoma, they may be effective in about 80% of people. And these are now being tested in glioblastoma against brain tumors. They're being used in ovarian cancer. And we are on the forefront in terms of the clinical trials using these sort of immunotherapies. And so we're also involved in some efforts to repurpose drugs that were used. There's some antidepressants that turn out to have some activity in cancer. And so we're trying to, as quickly as possible, test and develop new treatments for our patients.
Dr. Neimer, thank you. Dr. Dela Fuente, we just had this question sent in to us. If you've been through immunotherapy, is there any indication that that will help your immune system fight off COVID-19?
We are not sure about that, I think we are getting more and more data about what happened with COVID patients, and basically looks that there are two different stages. A first stage when you are firing the virus, and a second stage when they are more like an inflammatory response. So I think it's very important to keep learning about this. We are seeing, that drugs that we use to, for example, decrease the swelling in related to the brain tumors, as dexamethasone may have a role in the treatment of these patients. So I think the data is emerging and coming along, and we need to follow that.
Doctor, thank you. Dr. Comatar, while it makes sense to direct resources and expertise to patient care from surgery to chemotherapy, should Sylvester slow down clinical trials and other non-clinical community efforts to reduce the risk of spread of COVID-19?
That's an excellent question. I would say that there's really two parts to that. I would say that the risk of spreading COVID through clinical trials and those community-based activities, as long as you're following protocol and there's testing and people are wearing masks, washing their hands, social distancing, I think the risk of COVID is relatively low. I think that the progress that comes through clinical trials is so important that it really needs to be a priority. The issue is when there's limited resources. And so I don't think the risk of COVID spread should limit clinical trials. But if there's limited resources, that's something completely different. If those resources are limited, of course, people should get the standard of care and their overall care first. Clinical trials then should be second, and then prioritized as opposed to what level are they, at what stage are they, which ones are the most promising. And so ideally, none of the clinical trials would be delayed. But if you have a lack of resources, then I think you need to prioritize which ones are the most promising, which ones help the sickest people, and which ones are the furthest along.
Dr. Comatar, thank you. And Dr. Neimer, we just had this question sent to us. Florida, after California, has the second highest rate of skin cancer, melanoma, which can go to the brain. What research and outreach is Sylvester developing considering the times of COVID-19?
Thank you very much. So we recently recruited Dr. Jose Lutsky, who is probably the most prominent melanoma medical oncologist in the state of Florida. And together with our researchers, both laboratory researchers and clinical researchers, we've been developing our Cutaneous Oncology program, a fancy version of calling it our skin cancer program. And so we recognize that given sun exposure here, that we have a lot of skin cancer, and we're absolutely prioritizing this as an area of future growth, is to build our melanoma program and to be one of the leaders.
Dr. Neimer, thank you. Dr. Dela Fuente, given the aggressive growth of certain cancer cells, how do you determine whether a patient can delay treatment or for how long?
So during the pandemic, some patients may not feel comfortable coming to our center. That's true. So we work with every patient to assess whether cancer treatment or an MRI or a follow-up visit can be safely delayed or not. And we create an individualized plan for each patient. And this is a team effort and an open dialogue with the patient and the family and our colleagues that help taking care of the patient. When we consider that it is not safe to delay care, then we take every precaution to decrease the risk of exposure to the minimum possible. We want to reassure patients and families that across the cancer center and the university, there are strict protocols in place to assure the safety of our patient and of course our employees as well. And these protocols get updated almost on a daily basis as new information become available.
Dr. Dela Fuente, thank you. Dr. Comatar, we just had this one sent in to us. What are some examples of amazing and unexpected recoveries that you have seen, and how often do you see them?
I think that's an excellent question. I think that in neurosurgery, we are fortunate to see those recoveries, not on a daily basis, but I would say certainly on a weekly basis. I think that, I don't want to mention any particular example, but obviously tumors can affect the ability to speak, the ability to move, the ability to see, the ability to think. And in neurosurgery, we have the privilege of operating on the brain and really having great recoveries. And for example, someone who couldn't see because they had a large pituitary tumor, which is pushing on their optic nerves, you take it out, they were blind before the surgery, now they can see. Someone who has a tumor that's pushing on their motor strip, which is the part of the brain which controls movement, and they couldn't move their arm, couldn't move their leg, you take it out, and now they're moving their arm or their leg. Or you had a tumor that's near speech, couldn't understand language, couldn't speak. You take it out, and all of a sudden they can speak again. And so I would say that we are fortunate to see those types of events, not daily, but I would say certainly weekly, and it's one of the best parts of our job.
Thank you, Doctor. And what about you, Dr. Dela Fuente? What are some examples of amazing unexpected recoveries that you have seen? This was just sent in to us, and how often do you see them?
Yeah, I think, as of course, we share many patients with Rick, and it's amazing when you see these patients, in and out of the hospital, like in 2 days for brain surgery. Sometimes the patient cannot believe it, how well they are doing right after brain surgery. And for us, also, sometimes we see patients participated in clinical trials, that ended up doing well, tolerated in a very, like drugs that are safe, and patients do better and live longer. So that's, when we see that, of course, is all what we want to see. So make our days.
You can see just by your smile, Dr. Dela Fuente. Thank you. Dr. Neimer, a two-part question that was just sent in from one of our participants. Are you seeing more forms of cancer in younger patients in the past decade than traditionally? And if so, what can you attribute that to?
Thank you. So the good news, at least if we think of pediatric patients, cancer remains a very rare event in children. And there has not really been an uptick in terms of the number of cases, and we've made great progress over the last few decades in children. Some of the other cancers that may affect adolescents, one of which is lymphoma. Lymphoma is actually increasing. We're not exactly sure why, whether it relates to the use of pesticides or other chemicals in our environment, whether it relates to certain immune exposures as we're growing up. Lymphoma is actually relevant because lymphoma can affect the brain. Both can arise from the brain and can also spread to the brain. And so lymphoma is one of the cancers that is going up and is affecting younger people. For the most part, we're making a lot of progress. You know, the people don't smoke anymore, so we're seeing less lung cancer, and many of the cancers are going down in terms of the incidence. Although with the population getting older and the population getting larger, we do see some more cancers. I just say pancreas cancer is another cancer like lymphoma that's actually been increasing steadily for reasons that we don't know.
Dr. Neimer, thank you. And Dr. De La Fuente, back to you. This one just sent in. Do you currently have a clinical trial for glioblastoma patients?
Yes, we have, as we discussed earlier, we have many clinical trials for gliomas, for astrocytomas, for glioblastomas, are different type of gliomas, including different approaches. So we can expand more about that. We have it in the upfront setting. We have clinical trials in the recurrent setting. But if someone has any particular question and want us to dig in about the options, they can contact us directly, email us, or send us the question. We'll be happy to answer that in a more direct way and something that really can answer the question.
Dr. De La Fuente, thank you. Dr. Comatar, how are you leveraging technology to keep patients safe and improve point of care experience and delivery?
So this is a big deal for our department. We really want to make sure patients understand that when they come to the hospital, either for a clinic visit or for surgery, that they're going to be safe. So for clinic, most of it is going to be telemedicine. The people who want to come in person, it's very safe. Everyone gets a brand new clean mask, hand washing, social distancing. We only have a certain amount of providers in clinic at any one particular time, so there's plenty of space. And then if someone is surgical, everyone gets 2 COVID tests prior to surgery. So they get one a few days before, and then they get one on the day before, so that people who undergo surgery are going to be negative, and then during surgery, everyone who's around them during surgery is also tested. Then they go to a dedicated neuro ICU where the nurses are negative, where they're around negative patients, and then these patients go home the next day. So their overall hospital stay is minimized, so their overall exposure is going to be minimized. So I think in brief, everyone gets tested. It's a throughput system where people get in and get out, and everyone around them is also negative. So the experience tends to be clean, safe, and the risk of any COVID contamination is very, very low. We actually looked at our surgical experience since the pandemic started, and we haven't had any patient who comes into the hospital negative and leaves positive. So whatever we're doing is clearly working.
Dr. Comatar, it sure is. Stay right there because we have this one just sent in and we want to get to this. There is so much stigma when the diagnosis is brain tumor and was known to be a quote unquote death sentence. How much has that changed recently from the past to now?
I would say it's changed drastically. I think for all the technology, which I discussed before, as well as our subspecialization and our experience, I think the outcomes for brain tumors has changed, really. I mean, obviously, there's going to be aggressive brain tumors that are malignant, that need clinical trials, that need chemotherapy, that need radiation. But even those patients can do very, very well. So I think that the comprehensive care, the fact that it's a multidisciplinary team, the fact that it's targeted therapy, I think overall, that these patients who used to do uniformly poorly, the overall prognosis is much better nowadays.
Thank you, Doctor. And Dr. Neimer, this one again just sent in. With regards to the improvement in pediatric cancer, I want to confirm that much of the improvements you referenced have been primarily in lymphomas. Can you provide a little more perspective on some of the more rare cancers in pediatrics like sarcomas?
Sure. The number one cause of death in children for the longest time was leukemia. And the progress that's been made in leukemia has been remarkable. And so children who develop acute leukemia have over 90% chance of being cured and living a long time. And so it's been supplanted actually by brain tumors in children, which are the number one cause of death, in part because of their the number of children who do get brain tumors. Things like sarcomas. So first of all, sarcoma is not one disease, it's many diseases. And while children rarely get cancers, for rare cancers in children, it's even harder to make progress. So we have a lot of researchers dedicated to researching sarcoma, developing breakthroughs there. It's an area, you know, the drug companies have tended to avoid pediatrics because the drugs sometimes are metabolized differently in children than in adults. The markets are smaller, and so it's been more difficult in general. More recently, the FDA has made it much easier for drugs that are approved in adults to be given to children, but still the studies that show the efficacy, sometimes in adults, to show that drug A is better than drug B, you may enroll 500 people with breast cancer or 800 people with breast cancer, and there aren't those kind of numbers for children, and so the progress has been much slower. And so that we continue using precision medicine to try to get drugs for kids with specific cancers, and we are making progress for everybody with cancer. It's never fast enough and it's never good enough.
And Dr. Neimer, that was our last question for this evening. Before we leave, we would love some final comments from you.
Thank you. So first, I'm going to say that although I'm wearing a suit tonight, I am also a practicing physician. I have my white coat behind me. And what I would say is I'd like to also talk a little bit about some amazing recoveries and things that I've seen. And two things in particular. One, we continue to find people who have the wrong diagnosis. We talked briefly about sarcomas. If you don't have the right diagnosis of the 70 types of sarcoma, you will not be treated properly. The same for lymphoma and other cancers. And so the pathologists at Sylvester are among the world's experts in making the right diagnosis. And what's also very reassuring for us, sometimes people are given a cancer diagnosis, they come to see our people, and we're told that in fact it's not cancer, it's an early form, or it's something that doesn't require treatment. And so I think it's very important to talk about the fact that you should get second opinions, where you're diagnosed matters. And then I'd like to close in part to address some of the comments about funding and where philanthropy could be most useful. You know, our belief really is it's all about the people. The people, the people, the people. We need to get the very best people here to Sylvester and the University of Miami, and then we need to give them what they need, which is sometimes the best instrumentation, the best scientists to work in the laboratories, the best access to the clinical trials, and the support. So if we do a clinical trial, we don't just figure out what percentage benefited and what percentage didn't, but why did one patient benefit from a treatment and the other didn't? And so the clinical trial system that we use to support Dr. De La Fuente, Dr. Comatar, is one that requires millions and millions of dollars of investment every year from the Cancer Center. And we're in a competition with other cancer centers to get access to some of these drugs that we can give first to our patients and derive the benefit here in South Florida. And so we've established some funds. We have a Director's Innovation Fund, for instance, and that allows us to be able to pivot. I also believe that if people have already gotten grants from the federal government and we can give them money on top of the grant, the research will go that much faster. And we're always in a race to find the cures now. We get asked, we all have patients that have died and the families call us up years later. The first question they always ask is, if my loved one had cancer now in 2020 instead of in 2010, what would be different? And the good news is the answer is generally it's completely different. The treatments now are completely different than even a decade ago for almost all cancers. And so the need is urgent for us to get the funds that we need to make progress. I want to thank you, Tony. You're a phenomenal moderator. You help us tell our story. We have so many stories to tell. Each and every patient and each and every family is so important to us, and we care for patients one at a time. And so making progress one at a time is what drives us as physicians and researchers.
Dr. Neimer, thank you so much. I am honored, and what an amazing hour. And thank you for all participants in tonight's Sylvester in the Know Town Hall. I mean, when you listen to Dr. Neimer, and when you listen to Dr. Dela Fuente and Dr. Comatar, after hearing all of these amazing and talented and passionate doctors tonight, we hope that you go away realizing how blessed and fortunate we all are to have them right here on our campus in South Florida. Now, please remember that a full recording of this program and the questions and answers will be posted online. You can look for that link in the coming days. And if you would like to support Sylvester's innovative research, visit miami.edu/Sylvester. And if you'd like to give to UHealth's response to COVID-19, there you can visit uhealthemergencyrelief.com. Now, you'll also receive a survey by email about tonight's town hall. Please take a moment to submit your feedback. It won't take you very long. What it will do, though, it'll help us understand your interest and improve our program. As always, from all of us here at the University of Miami, after this remarkable hour, we wish you and your family a good health. We ask you to stay safe, and remember, it's always about the you. Good night, everyone.